Good afternoon, everyone. It is 12 noon, so we will get started. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thanks the diverse Indigenous peoples whose presence marks this territory on which people of the world now gather. It is a pleasure today to have a guest speaker coming to us from the Jewish General Hospital, Dr. Ernesto Schiffrin, who's very much one of ours and is known, I think, to most of you on this call. Dr. Schiffrin is Physician-in-Chief Emeritus at the Jewish General Hospital. He is Director of Hypertension and Vascular Research Unit at Lady Davis Institute and the JGH Cardiovascular Prevention Centre. He is the Distinguished James McGill Professor and former Associate Chair, Department of Medicine at McGill University. Dr. Schiffrin was born in Buenos Aires, obtained his MD from University of Buenos Aires and a PhD in experimental medicine from McGill. He's a specialist in internal medicine, subspecializing in cardiovascular medicine and hypertension. His research addresses mechanisms and treatments of hypertension from molecules and cells to humans, and renin-angiotensin-aldosterone, endothelin, and natriuretic peptide systems, and inflammation and immunity's role in vascular remodeling. He is the author of 641 publications, many book chapters, editor of 4 books, has a H-index of 137. For those of you on the line who are trainees, something to aspire to. Not many people around you have an H-index of 137. He has been president of the Canadian Hypertension Society, chair of the Council on Hypertension of the American Heart Association, and really it goes on and on and on because Dr. Schiffrin is, as you can probably figure out by now, is obviously internationally renowned and acclaimed researcher and distinguished professor. I'm not going to spend more time, Ernesto, on your brief bio because there's so many great things to say, but I will let you proceed with speaking. It's really a pleasure. It's an honor to have you here, somebody with a Lifetime Achievement Award in hypertension and chair of the jury de Prix Galien Health Research Foundation. So obviously our expectations are high, Ernesto, after all that. So thank you so much for being here today. And thanks everyone for joining us. The floor is yours.
Thank you very much, Dr. Janetti, for this too kind introduction. What I'm going to be doing in the next perhaps 50 minutes is talking to you about new developments in the field of hypertension, which has been kind of boring for some over the last 20 years, where we have seen few really extraordinary developments or breakthroughs. But now we're going through an era of explosive new knowledge and new treatments and new mechanisms. And that is what I'm going to try to very briefly, kind of bird's eye view, provide you in my presentation. Let me first start with my disclosures. This first slide gives you an idea from last week's Cardiovascular Research issue of the role of hypertension and different cardiovascular risk factors, and you can see that hypertension is up there with dyslipidemia and insufficient physical activity and unhealthy diets as major cardiovascular risk factors. And which is the most frequent cause of burden of disease? Difficult to say among these most important causes of cardiovascular disease. But one thing we know is that hypertension is the cause or number one cause of mortality in the world. And in this slide from a very recent issue of Circulation shows in dark green the countries where mortality is the least, like Canada, some countries in South America, Australia, New Zealand, Japan, and Western Europe, whereas in many states of the United States, mortality is much higher. And of course, in Africa and Asia, mortality is even higher, as shown by the brown and dark brown or purple color. So hypertension is a major cause of morbidity and mortality. Hypertension has been defined for many years as blood pressure is equal to or higher than 140/90. However, since SPRINT, some of us have thought that, and this is an editorial that I wrote in the journal that I'm editor-in-chief of with two of my associate editors at the time, arguing for a new definition of hypertension of 130/80, which was the entry criteria into the SPRINT trial, the systolic blood pressure intervention trial, which was carried out in the United States and Canada. And you can see in the next slide that when you look at the prevalence here in Canada from Statistics Canada, as published in the American Heart Association and American College of Cardiology, if you use 140/90 versus 130/80, of course, the prevalence is much greater with 130/80. And you can see as well that by the time people are close to 80 years of age, the prevalence is almost 80%. So this is an extraordinarily frequent condition that is associated with huge burden of disease and mortality. As well, what we have seen over the last few years with globalization is that hypertension has increased dramatically in the middle and low-income countries as a result of poor nutrition associated with globalization, stress, changes in culture and lifestyle that have been, in fact, nefarious. And the result is that today, hypertension is so prevalent in low and middle income countries that most of hypertension in the world occurs in these countries rather than in the income countries. Now, when we look at Canada, using 140/90, which is the definition of hypertension in Canada, according to the Hypertension Canada recommendations, about a little bit more than 6 million adults aged 30 to 79 have hypertension. And interestingly, about 50% hypertension has been, control has been achieved. This according to data from the WHO. And you can see here that about 80% are diagnosed or are aware, 73% are treated, and 60% are controlled, some of the highest levels of control in the world, only surpassed by the control achieved by Kaiser Permanente in Northern California, where a particular algorithm for treatment of hypertension that is carried out in a very homogeneous way allows very high levels of control. But if we compare our achievement in Canada with the United States, you can see here that awareness is quite high in the United States, both in males and females, and in different ethnicities. Treatment is relatively high, about 50%, but control is dismal. 20% to 28% of individuals with hypertension, either male or female, are controlled in these different ethnicities in the United States. And this is particularly serious in the southeast of the United States, what's called the stroke belt. In the rest of the world, control of blood pressure is dismal, is even worse than what you're seeing in this slide. Now, hypertension, as you know well, is a major risk factor, the #1 risk factor for heart failure. It's a major risk factor for atrial fibrillation, for chronic kidney disease, for aortic syndromes, for dementia, for coronary artery disease, and it is the #1 risk factor for stroke. However, in this publication, you can see from the trialist collaboration as published in Lancet that even small reductions in blood pressure, a few millimeters of mercury, will result in a reduction in major cardiovascular events. And so I really advocate for, of course, achieving goal blood pressure, but at least lower blood pressure somewhat, and that already will bring about a benefit with respect to outcome in patients. And this comes from all these trials that you see here. I won't go into the details of each one, but the fact is that even a mild lowering of blood pressure will result in improved outcome. Now, let me move on to resistant hypertension, because this will lead me to many of the new developments in hypertension. So blood pressure that remains above the therapeutic goal in spite of concurrent use of 3 antihypertensive agents of different classes, of which one should be a diuretic, and the others a renin-angiotensin system inhibitor and a calcium channel blocker at maximum or maximally tolerated doses is the definition for resistant hypertension. It is also present if blood pressure is controlled, but the patient is requiring more than 4 antihypertensive drugs. The more severe hypertension results in more frequent cardiovascular complications, including stroke and heart failure. Its prevalence is about 15% or 13 to 18%, depending on the different studies. And it's important to exclude apparent resistance due to non-adherence to treatment. I remind you that a Canadian study showed that 25% of patients do not fill their prescriptions, and about 50% of patients may not take their medication, at least as prescribed. And finally, the most important point is correct measurement of blood pressure. As you're aware, blood pressure, one of the most important clinical parameters that we measure, is one of the ones that is carried out in the most sloppy fashion. And of course, in Canada, we've developed automated office blood pressure measurement, which allows a partial, at least, elimination of the white coat effect, and allows as well quite rigorous blood pressure measurement in the office. We're also in favor of ambulatory blood pressure measurement when it is indicated, and particularly in most patients, I ask all my patients to do home blood pressure measurement, and in fact, I use it for diagnosis and follow-up of patients. And I recommend that you all require blood pressure measurement at home, because it, of course, eliminates the white coat effect and allows a reliable measurement of blood pressure that can allow you to appropriately treat your patients. Now, in the Kaiser Permanente study, here you can see the effect of hypertension, of resistant hypertension on heart failure, on end-stage renal disease, ischemic cardiac events, stroke, and mortality. And importantly, the risks for patients with CKD are much higher, because they have a much higher prevalence of resistant hypertension than the general hypertensive population. And CKD patients with resistant hypertension have markedly increased incidence of cardiovascular and end-stage renal disease compared to those without resistant hypertension. Now, this is from an invited review that is in press currently in a British Medical Journal that I've written with Naomi Fisher from the Brigham in Boston. And this gives you the approach to diagnosis and evaluation of resistant hypertension. As I mentioned, the definition requires the use of 3 drugs at maximal or maximally tolerated doses, excluding apparent resistant hypertension, confirming adherence to medicines, difficult to do, ensuring proper blood pressure measurement technique, very difficult as well, and ruling out the white coat effect with home blood pressures. Improving adherence by prescribing agents dosed once daily and using fixed dose single pill combinations in order to reduce pill burden. And if blood pressure is still at goal, then this is true resistant hypertension. And it's important in true resistant hypertension to investigate secondary causes of hypertension. And I underline particularly primary aldosteronism. We have come to realize that primary aldosteronism is much more frequent than we used to think when we diagnose primary aldosteronism in patients with hypertension and hypokalemia. Very often it's present without hypokalemia and typically associated with resistant hypertension. Of course, chronic kidney disease, renal artery stenosis, sleep apnea, and if clinically appropriate, investigate pheochromocytoma, paraganglioma, Cushing's, or coarctation of the aorta. As to management, lifestyle modification, and the TRIUMPH study has recently demonstrated the significant effect of lifestyle modification with low-salt diet, weight loss, and alcohol restriction. I remind you that any amount of alcohol raises blood pressure, and that Canadian recommendations based on the UK Biobank now recommend 2 drinks a week. This is difficult to achieve in some cases, and I recommend to my patients drink less. Limit exacerbating drugs. I'll go back to this, and of course, manage secondary hypertension or investigate secondary hypertension. Importantly, diuretic intensification, especially with CKD, and replace thiazides with chlorthalidone or indapamide. The recent study by Agarwal from Indianapolis showing that chlorthalidone is effective even with relatively advanced degrees of chronic kidney disease is something to remember. And I use a lot of chlorthalidone. And finally, you can appeal to the miracle drug, spironolactone, and I'll come back to spironolactone. I've used spironolactone for a long time, and now the Pathway 2 study has solidified the role of spironolactone in resistant hypertension. Eventually, when it is approved in Canada, and it's about to be approved or has recently been approved, but it's not been announced, renal denervation. And I'll dedicate some time to renal denervation, which was a major contribution of Naomi Fisher, who's an expert in renal denervation, for this review. And eventually referral to a hypertension specialist for addition of other medications such as beta blockers, alpha-1 adrenergic antagonists, or centrally acting alpha agonists. I will dedicate a lot of my presentation today to discussing new agents such as dual endothelin ETA-ETB receptor antagonists, non-steroidal MRAs I'll just briefly discuss, aldosterone synthase inhibitors, the reduction of angiotensinogen with interference RNA, or repurposed agents such as Entresto, valsartan, sacubitril, SGLT2s, perhaps GLP-1 agonists, and finally sildenafil that is used in resistant hypertension in some countries. So what are interference substances that you should take into account? Of course, we all know about non-steroidal anti-inflammatories or combined oral contraceptives and hormone replacement therapy, but you have to remember recreational drugs such as cocaine, amphetamines and derivatives, anorectic agents, stimulants for ADHD such as methylphenidate, decongestants, antidepressants are some of these agents, and as well biologic agents such as tyrosine kinase inhibitors that act through vascular rarefaction, VEGF inhibitors such as bevacizumab, immunosuppressive drugs, and finally, exogenous steroids such as glucocorticoids, mineralocorticoids, and herbs and supplements. I remind you of licorice, which through inhibition of 11-beta HSD hydroxysteroid dehydrogenase type 2 will result in cortisol acting on the mineralocorticoid receptor and induce apparent mineralocorticoid excess. So which are the approved drugs? I've mentioned RAS inhibitors such as ARBs and ACE inhibitors, calcium channel blockers, and diuretics. And remember to substitute a thiazide-like diuretic for chlorthalidone or indapamide. Fourth line is the mineralocorticoid receptor antagonist, spironolactone, or the less potent eplerenone that has to be dosed twice daily. Additionally, approved classes include beta blockers, central alpha agonist, hydralazine, and minoxidil. Why treat aggressively resistant hypertension? I've shown you that resistant hypertension is associated with increased mortality and increased incidence of cardiovascular events. And one thing that has been recently demonstrated, this is a study by Roland Schmieder from Germany. When you use single pill combinations versus multiple pill combinations in this START study, you can see clearly that all-cause mortality is reduced by using single pill combinations, probably because the reduced burden of pills results in a more adherent patient that takes the medication as prescribed. I just want to briefly mention again Pathway 2. This is the Lancet publication of the trial of spironolactone demonstrating its efficacy in resistant hypertension. And this recent publication in Cardiovascular Research from last week shows that indeed spironolactone over here, you can see, is the most effective intervention of these different medications or devices that you can use in resistant hypertension. So, to recapitulate, in the management of resistant hypertension, substitute a long-acting thiazide-like diuretic such as chlorthalidone or indapamide. Add a mineralocorticoid receptor antagonist such as spironolactone or eplerenone. Finally, add a beta blocker or a combined alpha-beta blocker. Eventually, hydralazine or minoxidil combined with a beta blocker and a diuretic. But by then, there is no real evidence, and the patient should be referred to a hypertension specialist. Now, let me start with what is really new. What is new in mechanisms of hypertension? This from a review that we wrote a couple of years ago with some of my trainees, and you could substitute aldosterone for angiotensin II and perhaps other agents such as endothelin. We were among the first to demonstrate the role of immunity and inflammation in the progression of hypertension, and particularly demonstrated this for the innate immune system, macrophages, using a mouse with a mutation in MCSF. We were able to demonstrate that blood pressure could not be elevated by any of the usual techniques such as infusion of angiotensin or mineralocorticoid administration. Shortly after, David Harrison at Emory demonstrated the role of T cells through the action of interferon gamma or interleukin-17. And more recently, we demonstrated that gamma delta T cells that are atypical T cells in a way, innate-like T cells that have the gamma delta subunits of the T cell receptor rather than the usual alpha beta subunits of the T cell receptor. And these are, we've demonstrated, are involved in both rodent and human hypertension. I'll very briefly show you some evidence. So a lot of research is being carried out on the potential role of inflammation and immunity in order to try to find new targets that will allow new medications to be used in the treatment of hypertension for those patients who do not tolerate our current available medications. This is, in fact, the study in Circulation that we published, where we demonstrated that in this particular cohort of coronary artery disease patients, when we modeled blood pressure with the concentration or frequency of gamma delta T cells, as measured by these constant units 1 and 2 with 4 probes, and correlated this with the actual systolic blood pressure of the patients, we had a significant correlation similar to that of sex and age. Sex and age added to the T cell, the gamma delta T cell was even more significant with a higher R squared. And in contrast, this was not the case when looking at coronary artery disease. So we've continued working on these gamma delta T cells, and this is the last slide that will not show that will show basic information. Here we looked actually with single cell sequencing at mice that were developing hypertension by infusion of angiotensin II at the adipose tissue in these mice around blood vessels, and women who were obese compared to lean women. And using single cell sequencing, we were able to identify the expansion of these CD25 high delta T effector memory cells in both conditions, in the rodents and in humans. And this is the way we look for new targets. And CD28 is in fact a co-stimulant molecule on the surface of T cells that, together with a T cell receptor, interacts with a CD80 and 86 that are the activated molecules in macrophages, contributing to the immunological synapse that results in activation of T cells. And we think that this may become one of future targets for treatment of these patients, as well as of vascular remodeling in hypertension, and perhaps particularly in obesity associated hypertension. As you know, obesity begets hypertension, and this is greater in the case of women compared to men. And so this is from an editorial that I wrote for this paper on the REGARD study that was published during the weekend online. And the REGARD study is a study of these 1,866 participants that included white and black individuals, where blood pressure elevation was examined over time. And what these investigators showed in the REGARD study was that certain cytokines were enhanced in blood over time and correlated with the elevation of blood pressure. And these included interleukin-1 beta, TNF-alpha, and interferon gamma. In contrast, in the black participants, only TNF-alpha and interferon gamma were elevated. And this is in blood, so we don't know what happens in tissues. And so this remains a complicated issue. But the important thing is that it looks like immune mechanisms in these two ethnicities may follow different pathways. So let me move on to what is new in treatment of hypertension. And here there's been, for 20 years, we only had one new drug, but unfortunately it was commercialized for heart failure, and that was Entresto. Actually, I put together valsartan and sacubitril and showed that it was a powerful antihypertensive. And in the study we did in rodents, it was extremely cardioprotective, and Novartis decided to commercialize it only for heart failure. And as you know, the ACC/AHA recommendations, the most recent ones, have upgraded Entresto. I like to call it Entresto Ernesto, but anyway, Entresto has been upgraded to first-line therapy for heart failure. However, it's still used in some countries for hypertension in East Asia. But Novartis has not wanted to, despite however much we try to insist on using it in hypertension, where it is very powerful, they have not commercialized it for hypertension. Then there's all these new agents, explosion of new agents, the dual ETA-ETB receptor antagonist aprocitentan, aldosterone synthase inhibitors, the non-steroidal MRAs. I won't be talking about these. They are not very powerful antihypertensives in contrast to spironolactone. And these include finerenone that has just been approved in the US and Canada for diabetic kidney disease. It's accessorone, which is approved in Japan for primary hypertension, ocedurenone and apparenone under investigation for CKD and diabetic kidney disease. The angiotensinogen synthesis inhibitors, zilebesiran, and the another agent that I will briefly address, the M-atrial natriuretic peptide, or MAMP, for which there is only one open label trial so far, single dose small trial, and firibastat that I will discuss very briefly, aminopeptidase A inhibitor. So Entresto, I feel very proud that we did this first study demonstrating its efficacy, lowering blood pressure and protecting from cardiac fibrosis in spontaneously hypertensive rats. And as I said, Novartis then went on to develop it for heart failure. But it could be repurposed for hypertension, and particularly for resistant hypertension. With respect to endothelin, we did many studies on endothelin, demonstrating that it was involved in elevating blood pressure. And here we were looking at human blood vessels obtained from biopsies of gluteal subcutaneous tissue. And whereas in normotensive individuals or stage 1 hypertension, there was no enhanced expression of endothelin, using in situ hybridization, we demonstrated that in stage 2 hypertension, in uncontrolled or difficult to control hypertension, the pre-pro mRNA for endothelin 1 was increased in the endothelium, and argued for many years that endothelin antagonists had to be used in hypertension. And although the first of the endothelin antagonists, bosentan, that is still used in primary pulmonary hypertension, was effective in lowering blood pressure because there was an elevation of liver enzymes. The company decided not to develop it for a chronic disease. In contrast, primary pulmonary hypertension, as you know well, is a rapidly progressive fatal disease in young women. And so bosentan was developed, and other endothelin antagonists were developed for primary pulmonary hypertension, where they are quite effective. It's only when aprocitentan, with very few side effects, a dual ETA-ETB receptor antagonist was produced, that we have an endothelin antagonist that has been used in resistant hypertension. Now, let me very briefly show you the vascular endothelin system. Endothelin produced in the endothelium over here, these yellowish cells that bear ETB receptors. And these are vasodilator receptors through the production of nitric oxide and prostacyclin. On smooth muscle cells, you have ETA and ETB receptors that are vasoconstrictor. And so what is the role of endothelin? Well, it looks like it may be a vasodilator in normotensive individuals and become a vasoconstrictor in hypertensive individuals. And so when you use aprocitentan, you block the ETB receptor on endothelial cells, which elevates plasma endothelin because these are clearance receptors, but you block the vasoconstrictor receptors on smooth muscle cells. Unfortunately, there are as well endothelin receptors in the kidney that induce natriuresis. So when you block endothelin receptors, you retain fluid. And I will get back to this in a minute. So this is the precision trial, which showed the effect of dual endothelin antagonist aprocitentan in resistant hypertension. and was published in The Lancet at the end of 2022. Here you have the study where patients on a standardized triple therapy, including an ARB, a calcium channel blocker, and a diuretic, were then randomized to placebo or to 12.5 or 25 milligrams of aprocitentan. And you can see the big placebo effect, and that's why it's important to look at blood pressure of the active compound minus the placebo. The lowering of blood pressure that persists over these 32 weeks, and then the FDA requested a re-randomization to the higher dose of aprocitentan and placebo. And you see that when patients are re-randomized to placebo, blood pressure goes back to the levels it had under placebo at the beginning of the trial, demonstrating the efficacy of aprocitentan, which is about close to 10 millimeters of mercury. Here you have the ambulatory blood pressure lowering, and as well the withdrawal phase. And here you have, and I'll ask you to concentrate only on the right part of the slide, the double-blind reduction in albuminuria and the withdrawal phase, where albuminuria increases again in the placebo treated patients. And I want to point out over here the benefit that patients with advanced chronic kidney disease present with this agent, which is important because as an add-on, when you consider chronic kidney disease and you're adding spironolactone, you start getting into trouble with potassium at eGFRs lower than 40, perhaps less with the new non-steroidal mineralocorticoid receptor antagonists, but in a way, endothelin antagonism would be superior in the sense that it would not induce hyperkalemia. On the other hand, it does induce edema and fluid retention, and so perhaps it has to be combined with a diuretic or, for example, an SGLT2 agent to reduce fluid retention. And so aprocitentan lowers standardized automated office and 24-hour ambulatory blood pressure, effect maintained over 48 weeks. Edema and fluid retention is the most common adverse event reported, which can be managed by addition or uptitration of a diuretic, and it may represent an alternative approach to treat resistant hypertension. Let me move on to another area where there's been extraordinary development. Here you have the zona glomerulosa of the adrenal cortex and the fasciculata, CYP11B2, aldosterone synthase through 11 hydroxylase activity, 18 hydroxylase, and 18 oxidase producing aldosterone. On the other side, in the zona fasciculata, the CYP11B1, slightly different from CYP11B2, has the same 11-deoxycortisol activity, produces cortisol that is secreted to produce glucocorticoid effects. Aldosterone synthase inhibitors will inhibit production of aldosterone. And what I show here as well is the difference between a mineralocorticoid receptor antagonist that blocks the mineralocorticoid receptor responsible for the genomic effects of aldosterone and the benefit of reducing aldosterone, which also has non-genomic effects through GPR30 on the membrane. So we need now a comparison of mineralocorticoid receptor antagonists with aldo synthase inhibitors in order to determine whether these differences in effects and the residual non-genomic effects in the presence of mineralocorticoid receptor antagonists represents a deficit with respect to aldose synthase inhibitors. Here is the first publication of baxdrostat, the first of the aldosterone synthase inhibitors. Here you see the dose-dependent decreases in blood pressure produced by baxdrostat. Over here, you see that aldosterone is reduced in plasma and the urine significantly by increasing doses of baxdrostat, whereas cortisol is unaffected. So aldose synthase inhibitors should not reduce cortisol, despite the similarity between CYP11B2 and CYP11B1. And indeed, there is a selectivity of these agents for CYP11B2 and reduction of aldosterone. So 2 milligrams of baxdrostat from the American Heart Association resistant hypertension session, the slide showing that baxdrostat reduced aldosterone levels, increased plasma renin activity without reducing cortisol. A favorable safety profile, and it has the potential to treat disorders associated with aldosterone excess, including hypertension and primary hyperaldosteronism. There are other aldosterone synthase inhibitors in development, lorundrostat in this particular publication, and dexfadrostat. I could have chosen easier names, but these are the names you will have to soon remember. And they are very effective in reducing aldosterone and may prove valuable in managing aldosterone-dependent hypertension and primary aldosteronism. Let's move on to another group of new agents, the interference with angiotensinogen production. This is from Rian Tawaz, the director of the MUHC RI, in the New England Journal of Medicine, explaining the difference between antisense oligonucleotides, for which there is one in development for angiotensinogen reduction, and small interference RNAs. And let me tell you that from work from the Iowa group and Paris group, it is clear that levels of blood pressure are correlated with the levels of angiotensinogen in the circulation. Angiotensinogen is the source of angiotensin-1 under the action of renin, which eventually converted to angiotensin-2 by angiotensin-converting enzyme. And so if you reduce angiotensinogen, you reduce angiotensin-2 as a result. So here is the initial study in the New England Journal of Medicine from George Bakris, zilebesiran, an RNA interference therapeutic agent for hypertension, which showed persistent reduction of blood pressure. And here you can see the changes in angiotensinogen levels with zilebesiran and the changes in blood pressure. With very few adverse events, mainly at the injection site of zilebesiran. Here, the recent publication last week in JAMA of the phase 2 study and my editorial, which insisted on the advantage of an iRNA injection every 6 months to improve adherence and lower blood pressure in patients with hypertension. Can you imagine our non-adherent patients under your supervision get every 6 months an injection of zilebesiran, and it lowers their blood pressure persistently for 6 months? Of course, we have to demonstrate that the blood pressure will be sustainable in the long term. It is for 6 months, and that there will be no eventual adverse side effects. Finally, there is this firibastat. Firibastat is also called EC33. It's derived from an agent that inhibits brain aminopeptidase A in the brain. And although there is a lot of data from preclinical studies that this agent is very effective in lowering blood pressure, when it was tried in resistant hypertension, as you can see here, there was no significant difference between placebo and the firibastat group. So this agent is still being developed on the basis of combining it with other agents, and we shall see whether it will turn out to be effective. It was effective in an initial study, but not in resistant hypertension. So those are the drugs. Now let's move on very briefly to the devices. I have a few more minutes, and all I will do is go very rapidly over the different trials to convince you that there's a lot of evidence in favor of these agents. They're not, or they're in the course of being approved in Canada. They were just approved by the FDA, at least the radiofrequency and the ultrasound renal denervation. Alcohol ablation, the Peregrine device, has not yet been approved. Cardiac neuromodulation is another approach. And finally, carotid baroreceptor modulation with the Mobius HD device has been canceled and is no longer recommended by any guideline. So this is the radiofrequency compared to the ultrasound, the Simplicity Spiral versus Paradise. I won't go into details. It's not my area of expertise. Naomi Fisher, my co-author in that review for British Medical Journal, is the expert. And essentially, what I want to show you is that renal denervation can be carried out with no disturbances to renal artery architecture, no reports of repeat renal artery revascularization, and no decrease in renal function, and so far with very few adverse side effects. Here you can see from the Spiral Hypertension Off-Med pivotal trial, the reductions in blood pressure around 5 millimeters of mercury on 24-hour ambulatory blood pressure and about 10 millimeters of mercury on office blood pressure. Over here, the ambulatory blood pressure reduction that you can see occurs throughout the day. This is the On-Med trial. Again, similar blood pressure reductions. And the same for ambulatory blood pressure. This shows ultrasound renal denervation, 3 different trials. And again, I just want to point out that there are many studies, all of which show very few side effects and effectiveness in the order of about 5 to 10 millimeters of mercury systolic blood pressure on either ambulatory blood pressure monitoring or on office blood pressure. Here, the three, the Radiance, the Solo, and the Trio trials, and you can see the results are all relatively similar. Here they're all together for a final look at the Spiral trials and the Radiance trial, showing systolic ambulatory blood pressure reductions in the order of 5 to 6 millimeters of mercury versus office blood pressure reductions in the order of 10 millimeters of mercury. My colleagues tell me that there are no complications. One is always concerned what happens if you are in an accident or you bleed through the GI or elsewhere, and if you get dehydrated, you have this permanent lowering of blood pressure. You cannot stop the pills. Here it is permanent, and will the patient suffer consequences from this? So far, it looks like there are no significant consequences. And so it looks that after more than 20 years without new antihypertensive agents, except for Entresto that has not been commercialized for hypertension, now we have new mechanisms, new potential targets, a plethora of new agents and new devices in development or already approved that show promise to improve adherence to treatment, to lower cardiovascular risk, and generate hope that we can improve outcomes in hypertension, the #1 cause of burden and disease and mortality worldwide. And with this, I thank you for your attention, and I'm open to questions.
Fantastic, Ernesto, Dr. Schiffrin. Great big thanks. Really fantastic presentation. You do not disappoint, as I suspected. Wow, really impressive to see this evolution of hypertension. I'm just thinking back of when I started my practice more than 20 years ago, and this is really, really impressive to see. People are invited to enter questions in the chat. I'm just going to start. I work in the heart failure world, and just a couple of points. Obviously, we've seen Entresto being extremely, really make a big difference for our heart failure patients, and I guess. I don't know what your thoughts are, but it's my understanding that this drug is going to come off patent in the next year or so. Do you think it's going to be sort of up there in terms of now having more access for hypertensive patients once it's more readily available? Or are we going to go, or should we be going to, knowing that compliance is an issue, should we be going to more definitive procedures like renal denervation or Q6 months injections? I just would like your thoughts on that.
Well, I think that that is an open question currently. I think that we need more agents. I have a lot of patients who don't take their meds, and then they come on a wheelchair with hemiplegia. They've had a stroke. I have a lot of patients who come back and say, no, this agent produced these side effects, this other one, and they have a long list of every single antihypertensive that has produced side effects that I have never heard about and that are not recorded in the literature. And so we really need to have alternatives. And I don't think that necessarily one agent will come before the others. Of course, an injection every 6 months. I was really enthused by this publication, and I wrote it in the editorial. I think that really this gives us a unique opportunity for even administering the medication under supervision when the patient comes every 6 months. So I think that that is an incredible opportunity that may replace ARBs and ACE inhibitors because it essentially acts through the same mechanism, except that it's an injection every 6 months and with no side effects so far, if it's sustained and so on. The aldose synthase inhibitors, I think we know that aldosterone in right amounts is necessary. In excess is very bad for you. There's a lot of atrial fibrillation associated with hyperaldosteronism. There's a lot of increased stiffness of vessels. And we know the benefits of blocking aldosterone in heart failure, as well as in hypertension and in chronic kidney disease, particularly in diabetic chronic kidney disease. So if we can really eliminate aldosterone with an aldose synthase inhibitor, I think it will be superior to the mineralocorticoid receptor blockers. The non-steroidal mineralocorticoid receptor blockers seem to be very effective in protection of the kidney, for example, but they're not great blood pressure lowering agents. So there's reasons for choosing one or another and using all of them in different patients. And as usual, we individualize therapy. So having more possibilities, I think, increases our ability to improve outcomes for our patients.
Fantastic. There's a question here about nitric oxide and benanin from beetroot. They are said to have effects on vascular endothelium and reduce systemic blood pressure. Is there substantial evidence for this?
Yeah, there's been some trials, actually one from the UK. I was the associate editor for the publication of that in Hypertension at the time, before I moved to the American Journal of Hypertension. And it seems to be effective, yes. But there hasn't been, I haven't seen further publications. But indeed, beetroot ingestion is associated with increased nitric oxide generation, and it lowers blood pressure. Does it protect from cardiac events or from cardiovascular events? We don't know that. So, as usual, we like to count bodies.
Yes, absolutely. There's a question about pulse pressure. Is this an important consideration in prognosis, just pulse pressure?
So until the 90s, we used to worry about diastolic blood pressure. Michel Safar, who died recently in Paris, and Stanley Franklin in the United States have been the ones who've produced a lot of the literature that shows that it's actually systolic blood pressure that drives the consequences of elevated blood pressure, not diastolic. And indeed, pulsatility is important, but it is difficult to deal with. So actually, we should concentrate on systolic blood pressure. What do we do about diastolic blood pressure? We know that diastolic blood pressure drives coronary perfusion. And so in the American recommendations, the recommendation is made that you should not lower diastolic blood pressure below 70 in elderly people because you can compromise coronary perfusion. In the Canadian recommendations, we argued for a long time, what do we do about this? And finally, we agreed that the important thing was to lower systolic. Unless you have danger signals about coronary perfusion in any way that they may manifest, you should not worry about the diastolic. But we did suggest that one should be careful about lowering diastolic blood pressure below 60 millimeters of mercury when lowering systolic blood pressure in individuals with predominantly systolic hypertension. I have to say that I have many patients who have very low diastolic blood pressures. If they don't have coronary artery disease and they don't have any manifestation, I really don't look at the diastolic blood pressure, but it's a consideration that is important. But we should not forget that we have to lower the systolic below 140 and preferably close or below 130. That's the goal.
A couple of minutes left. There's a question here on nutrition diet questions. Is there an effect of high versus low salt diet and the trials and people given aldosterone synthesis or aldosterone synthesis blockers?
So every person who has hypertension should be on a low salt diet. We recommend 5 grams of salt per day. Average intake in Canada is about 10 grams. So we have to work on this. Anything that is prepared, foods that are prepared, they all have a lot of salt. So my recommendation to my patients is eat natural products. Of course, they are more expensive. Veggies, fish is important, a source of omega-3 fatty acids, perhaps acting as a cardioprotective or cardiovascular protective agent. We don't know if it's the omega-3s that are the benefit that fish provide, but I tell all my patients to eat fish 3 times a week, eat lots of veggies, eat some fruit. The DASH diet is what we recommend, which includes dairy products. So nutrition is very important. And you saw in my first slide, unhealthy diets, one of the major cardiovascular risk factors, together with blood pressure, dyslipidemia, and lack of exercise. So a healthy diet is critical. And what was the question about aldosynthase inhibitors?
Yeah, aldosterone synthesis or angiotensin synthesis blockers.
Yes, so they're different. With aldo synthase inhibition, you do see some rise of plasma renin, but all these patients will probably be on a renin-angiotensin blocker, be it one that reduces angiotensinogen or one that reduces production of angiotensin 1 or one that produces reduction of angiotensin 2. So even if plasma renin activity increases, because of aldo synthase inhibition, the patient will be protected. So these agents cannot be used alone. And we don't use spironolactone alone. We use it together with other agents. So the rises in plasma renin are not critical.
Thank you so much. It is past 1 o'clock, so I'll have to close out the rounds. Dr. Schiffrin, obviously, really fantastic lecture. Thank you so much. And congratulations, really. I know you've played a very big role in advancing this field. You and obviously Rianne Tewas, our Director of Research here at the Institute. So thank you so much for all the work you've done. And thank you for this fantastic medical grand rounds. I wish everybody a wonderful afternoon. Thanks.
Thank you.
Thanks. Bye-bye.
Bye.